Hi, Dr. Grace. Thank you for being with us. My name is Madeeha. I'm representing MedEdge today. Could you please tell us a bit about yourself?
So my name is Grace van Leeuwen. I'm a pediatric cardiac intensivist and co-director of the ECMO program at Sidra Medicine in Qatar, where I work for the last 6 years.
I'd just like to ask you about ECPR in pediatrics. Is it even possible?
Yes. Well, we have a good amount of patients that require ECPR, and we can support them in a good way.
Okay. And how young is too young?
So there's no such a thing as being too young. Sometimes we have some constraints regarding to the weight of the baby. It's very difficult to cannulate a baby that is smaller than 2.5 kilo. So I would say they can be too small for cannulation. And another population that we usually don't offer ECMO, but this has to be center-based, is the premature babies. So babies who has the gestational age less than 34 weeks, we think they are a very high-risk population that usually we avoid any kind of ECMO for them. There's not an absolute contraindication nowadays. We have good publication showing that even the smallest patients and younger patients in the gestational age can do good. But we usually still think when we have this population, we think about not offering a VA ECMO. But it's not actually the age. So they can be 1 day old, they can be 0 day old. We can offer ECPR for them.
Constraints or considerations to take into account?
For ECPRs. So patient selection is very important. You need to know what this ECMO is aiming for. Is it going to be bridge for decisions, going to be especially very young neonates. Sometimes you don't have the full diagnosis, so you can place them on ECPR. Then you can give more evaluation to understand what is their disease and if you're going to be able to help them somehow. And when it's, of course, bridge for recovery, you can offer ECMO for this young population with no problem, even on ECPR. Another thing that you should consider is that we know by the literature that the cardiac patients, the children with cardiac conditions, they do better on ECPR than the children without a cardiac disease. It's not a contraindication not being a cardiac patient. For example, you can give ECPR for a very sick ARDS patient, or you can give ECPR for a very sick septic shock child. But then we know that the results are not as good as the cardiac patients.
And is there anything we can learn from the adult population about ECPR to extrapolate in children?
I think what the adult population does that we are using already in the pediatric population is how they train. We know that other than the patient selection, that is very important. This is proven for the adult population that patient selection is very important. That's what we do for pediatrics. We have a different population, but we know that if select the patient in the correct way, we are going to probably going to have better outcomes. So this is one thing. But the other thing is that they are prepared. So we know that to have ECPR, you have to be fast. You have to provide a very high quality CPR while you're preparing for the ECPR. You need to have checklists. You have to have a very strict protocol for initiation of the ECPR. And so these, the adult ECMO centers they have, and we use the same mindset for the pediatric population. What we cannot use from the adult strategy is that as the diseases are very different, for the adult population, they usually do out of hospital cardiac arrest. So they put patients who had arrest outside the hospital setting on ECMO, on ECPR. This is very rare for the pediatric population. Due to the cannulation technique being different, and especially because the diseases that lead an adult for a sudden arrest are very different from when a kid has a cardiac arrest. So for all of these reasons, we usually don't offer out-of-hospital ECPR for kids.
I guess there's a lot of governance and policies on sort of standards that you need to follow when we're doing ECPR as well.
So this is very important. We always compare deploying ECPR with F1 change of the tires. You know, when you have the pit stop, everybody knows exactly what they have to do, and they have to be very efficient and very fast. That's the same thing we have to do with ECPR. So your team has to have all the resources ready. Your team has to be highly trained. Your team has to have gone through a lot of simulations to keep their skills. And so with that, you can be very fast when you start ECPR. Our aim is usually to have no more than 60 minutes from the arrest to the flow being running in the patients. Ideally, we wish we can always have less than 45 minutes, but the goal is at least 60 minutes. So for that, we need to be very prepared.
And just talk about the conference a bit. What excites you about conferences like this? What do you enjoy about?
SWAAC ELSO is always a fantastic conference. First of all, because the region have a very great hospitality, so you always feel very welcome coming here. And secondly, when you see what we can do in our region and how we can collaborate with our peers that are close to us, this is really fantastic. Even though we always go to conferences in the US or in Europe, we don't need that, because what the expertise and the level of care that we have here in the region is very high. So it's very good for us to have this network, to see what other centers in the region are doing. So it's usually a very fantastic conference.
And it's great to see that the evidence base is being built here as well. Lots of research.
Yeah.
There now and being built.
There's a lot of publications coming from this region, and we are very proud of it.
Any final comments or thoughts?
But I think ECPR for children is something that we really need to improve. The mortality is still the highest among all the pediatric and neonatal ECMO, but of course they are the most severely ill children. So we need to continue to have this learning mindset and continue to improve all the programs providing ECPR for children.
Thank you very much.
Thank you, dear. Thank you so much.